Everyone, welcome back to today's video, and in this video we will be talking about blunt abdominal trauma. So what we will be discussing? We will be discussing the causes, the sign and symptoms, diagnosis, management, spleen and liver injury specifically, and the fast examination. And we will talk little bit about the penetrating abdominal traumas as well. So what are the most common causes of blunt abdominal trauma? So what you have to remember is that the most common cause of the blunt abdominal trauma is motor vehicular accident. Other causes can include assault, falls, blows to the abdominal, or recreational accident. But from this slide, you will remember that the most motor vehicle accidents are the most common cause. Coming to the common injuries. So what are the most common organs injured in blunt abdominal trauma? Solid organs like spleen, liver, or injuries. Hollow organs can be injured, but they are less common as compared to solid organs. And there can be other injuries like pancreas, diaphragm, or mesentery can be injured also. But the most common organs injured are spleen, liver, and kidney because these are the solid organs. Okay. So, what are the signs and symptoms of blunt abdominal trauma? So, there can be abdominal pain and tenderness, but the absence of abdominal pain and tenderness doesn't rule out the blunt abdominal trauma. So, if the patient comes to you and says that I don't have abdominal pain or tenderness, that doesn't mean that he doesn't have any internal injury. You will always do the management as if there is an internal injury. You will check for internal injury. We will discuss about that. There can be abdominal distension or swelling. There can be nausea or vomiting, lightheadedness or fainting due to blood loss. And this blood loss can be internal also and external also. But in blunt abdominal trauma, mostly it is internal blood loss. There can be weakness. There can be bleeding in the urine or feces if there is a urethral injury or there is injury to bladder or there is injury to the gastrointestinal tract. Then there can be blood in the feces or urine. Then there can be signs of shock or cardiovascular collapse. Okay, so we will talk about this, that how much blood loss is required for the cardiovascular collapse or the shock. We will discuss about that. Another important sign is the seatbelt sign. So you are seeing the photographs on the screen right now. So when we travel in a car, we wear a seat belt like this or like this. The seat belt can go through this area. So these are all the seat belt sign. So if they show you a photograph in the exam, ask you that what is this? This is seat belt sign, and it is seen in the blunt abdominal traumas due to motor vehicular accidents. And motor vehicular accidents are the most common cause of the blunt abdominal trauma. So how much blood loss is required to develop shock or cardiovascular collapse? So if the blood loss is less than 15%, that is called class 1 shock. And body's compensatory mechanisms are often enough to maintain the blood pressure or the heart rate. But if the blood loss is more than 15%, if it is between 15 to 30%, that is called class 2 shock. It is often the stage where symptoms of shock begin to express, like hypotension, tachycardia, increased breathing, drop in the urine output. These are all the signs of or all the symptoms of shock. So they will appear if the blood loss is 15 to 30%. If the blood loss is more than 30%, it is called class 3 or class 4 shock. This severe blood loss can lead to significant drop in the blood pressure, and this is a medical emergency. So more than 30% of blood loss is a medical emergency. 15 to 30% is where the symptoms begin to appear. Less than 15%, body's compensatory mechanisms are enough. So this is important for the shock as well. If you study shock, we will discuss that in the shock video. So what are the obvious sources of this much blood loss? What are the obvious sources? So it can be a large hematoma. It can be a bleeding vessel in the neck or leg. You will see that. Hemothorax. You will see the signs and symptoms. So these are obvious. These are not the hidden sources of blood loss. You can easily identify that in the emergency. But what are the hidden places where there is a large amount of blood loss, but you can miss it? So it can be hip fracture. So if there is a hip fracture, blood can collect in the pelvic cavity, but can be picked by X-ray. It can be missed on physical examination. That's why I am saying it is hidden. But it can be picked by X-ray. Similarly, if there is a pelvic fracture, it can be picked by X-ray, but you can miss it on physical examination. Abdominal bleeding. This is missed on physical examination, and the X-ray will be negative as well. So what will you do? You will do fast if you suspect this. We will talk about fast in the coming slides, but this is the classical location which is not picked on physical examination or imaging studies. Okay. So what is fast? As I have mentioned it in the last slide, what is fast? Give me 1 second. So fast is a bedside ultrasonographic examination used in abdominal traumas. So what is the goal of fast? Goal is to identify the free fluid presumed to be blood. So if they ask what is the goal of the fast, it is to identify the free fluid. It you will not say that it is to identify the blood. It will just identify that there is some fluid, and we know that the most common fluid is blood. But goal is to identify the free fluid in the abdomen. It is used to examine the key areas where the blood collects. What are the key areas where the blood collects? Right upper quadrant, left upper quadrant, pelvis, and heart. Okay, so these are the hidden areas. You cannot identify that like in the physical examination. So that is why we do the fast used in the blunt chest or abdominal trauma. So previously, when like 20 years back or like 50 years back, we used to do diagnostic peritoneal lavage. What do we mean by diagnostic peritoneal lavage? We will insert a needle, take the fluid out, and examine that if it is blood or not. But now we have this fast ultrasound, which is focused assessment with sonography for trauma scan. It is a bedside thing, and we can just do the ultrasound. We can use the ultrasound to detect any free fluid, and then we can know that that there is blood inside the cavity. So this is super high yield. Read about fast, and we will discuss about fast in this video as well. But this is a super high yield topic for USMLE as well as the MCCQE. I hope this is clear. So how do we manage the patient? How do we manage the patient when he or she comes with a blunt abdominal trauma? So this flowchart is from White Coat Companion. So if the patient is not hemodynamically stable, first we will check whether the patient is hemodynamically stable or not. So if the patient is not dynamically stable, we will do the ultrasound, that is fast, that we have discussed, because fast is a very fast examination. It doesn't require much time. We will not wait for CT scan, we will not go for ultrasound, we will immediately do the fast or a diagnostic peritoneal lavage, which is not used much often nowadays. So we will do fast. If fast is positive, what do we mean? That there is blood, so there is a free fluid, or there is blood inside the cavity, as we have discussed before. So we will do laparotomy, immediate surgery, because there is blood loss. But if it is negative, if fast is negative, you cannot see any free fluid, then what you will do? You will do resuscitation or stabilization. So listen to this. So fast is negative, but patient is hemodynamically not stable. So what do we mean by that? There is no fluid as it is not detected by fast. There is no free fluid in the cavity. But then why is patient hemodynamically unstable? So that means there is no blood in the cavity, but there is blood leakage. The patient is losing blood. So when it can happen? It can happen in extra abdominal hemorrhage. So in extra abdominal hemorrhage, you will not see any free fluid in the fast examination, but you will see that patient is hemodynamically unstable. So that means there is extra abdominal hemorrhage. There is no free fluid in the abdomen, but somewhere else. And there can be retroperitoneal hemorrhage as well. Retroperitoneal hemorrhage can be missed. So what you will do? You will do abdominal CT in that case, because you cannot find anything on fast or the ultrasound, but patient is hemodynamically uh, not stable. So that is why you will do abdominal CT. So if the patient is hemodynamically stable, if the patient is stable, there is no like BP is okay and everything is okay, there is no tachycardia or anything, then that is then you will see what is the risk. If it is a low risk, you do a physical examination and you don't see any risk on physical examination. So that means there is no emergency because patient is hemodynamically stable. Okay, and there is low risk. So you can afford to do serial examination or ultrasound. Patient is not at risk. But if patient is at high risk, patient is hemodynamically stable, but is at high risk, like he has got a severe motor vehicular accident, he sees some signs on you see some signs on physical examination, then you will go for ultrasound. Fast is for emergency when the patient is not hemodynamically stable. CT scan is when patient is hemodynamically stable, then you will go for abdominal CT, because this is more sensitive test. This is a more sensitive test. This is a faster test. So in this if there is emergency, you will go for ultrasound, and if there is no emergency, you will go for abdominal CT. So this is a very high yield flowchart for MCCQE and USMLE. So that is why I am discussing this in detail, and I am giving so much time to this slide. So I hope this is clear. So please remember this flowchart. Liver injury. So liver is the most frequently injured abdominal organ in blunt trauma. Remember we discussed that the solid organs are the most commonly injured organs in blunt trauma. Out of these, liver is the most frequently injured organ. But the bleeding, it is less likely to cause major blood loss and shock. So causes, sorry, spleen causes blood loss more than liver. So if they ask you which organ cause more blood loss, like in which organ injury there is more chances of loss of blood, then the answer is spleen. But the most frequently injured abdominal organ is liver. We will discuss about this in the spleen injury as well. So diagnosis in unstable patient we will do fast as we have discussed before, because fast is a very fast test. If there is a stable patient, we will do CT scan with contrast. So unstable patient, fast ultrasound. Stable patient, CT scan with contrast. Hemodynamically unstable patients usually require surgery, as we have discussed in the last slide. But most stable patient can be managed without surgery. Some patients can be treated with hepatic embolization. So, if the patient is hemodynamically stable, they ask you sometime in the exam that if you suspect liver injury or if the liver injury is diagnosed but the patient is hemodynamically stable, then will you observe or will you perform surgery? So, the answer is that you will observe. I will discuss that in the liver injury video as well, and we will discuss this in detail in the context of spleen as well in the later part of this video. So there is something called Pringle maneuver. What is Pringle maneuver? Pringle maneuver is used to control the liver bleeding in two cases mainly. If you are performing a surgery and you want a clear surgical field, you perform a Pringle maneuver. We will discuss what a Pringle maneuver is. Or if there is a liver injury and you want to control the bleeding or want to know the source of bleeding, then you will do the Pringle maneuver. So what is Pringle maneuver? So there is something called hepatoduodenal ligament. It connects liver to duodenum. And this hepatoduodenal ligament contain hepatic artery, portal vein, or common bile duct. So if you clamp this hepatoduodenal ligament, what will happen? The bleeding will be controlled if it is from the hepatic artery or portal vein. Blood bleeding will continue if it is from inferior vena cava or hepatic veins. So this can help us in understanding the source of bleeding, as well as it controls the liver bleeding. So clamping is done intermittently to prevent ischemia. What does that mean? If we clamp the hepatoduodenal ligament, the blood supply, the hepatic artery will be blocked, vein will be blocked. So liver can undergo ischemia. So we do intermittent clamping so that liver doesn't get ischemic. Okay, so this is Pringle's maneuver. It is used to control bleeding again, control bleeding in cases of surgery or injury, and it is used to understand the source of bleeding as well. So this is Pringle maneuver. Now coming to splenic injury, it is the most frequent cause of serious bleeding. The most frequently injured organ is liver. Most frequently injured organ is liver, but most frequent cause of serious bleeding in blunt abdominal trauma is ruptured spleen, and it is most commonly associated with lower left rib fracture. So one more thing about splenic injury, if there is a splenic injury, there can be pain in the left shoulder. Okay, so there can be pain in the left shoulder due to irritation of diaphragm. So remember this, irritation of diaphragm. So most frequent cause of serious bleeding, commonly associated with lower left rib fracture, and there can be pain in the left shoulder. And diagnosis in unstable patient, as we have discussed before, is with fast. Diagnosis in stable patients is with CT scan with contrast. Remember, this is more sensitive. This is faster. So fast is faster, but CT scan is more sensitive. So if the patient is hemodynamically stable, then you will go for CT scan with contrast. We have discussed in the flow chart before. And the treatment is observation, embolization, and surgery. So indication for non-operative management. This is given in the Canada question bank as a question. So I'm specifically discussing as per the present practice, we don't always go for operative management in spleen injury. So when we will go for non-operative management, if the patient is hemodynamically stable, there are no signs of peritonitis. What are the signs of peritonitis? It can be guarding, it can be rigidity, it can be rebound tenderness. All these are signs of peritonitis. There is appropriate monitoring environment. So if you can monitor the patient, then you will go for non-operative management. Otherwise not. Absence of any other injuries requiring immediate surgery. If there is a hollow organs injury, then you will not go for non-operative management. So this will be discussed in the spleen injury video, but I am just mentioning it briefly here. So consider non-operative management even if there are high grades of spleen injury. Even if grade 4 or 5 spleen injury is there, you can go for non-operative management. So this is actually come as a surprise to you, but remember this, even in high grade spleen injuries, if the patient is hemodynamically stable, there are no signs of peritonitis, appropriating monitoring environment, absence of other injuries requiring immediate surgery. Then even in grade 4 and 5 injuries, you can go for non-operative management. Age doesn't matter. If the patient is old, very old, then also you can go for non-operative management. Neurological status doesn't matter. So I know these all are surprises to you. As a general rule, that all these are seems to be very ominous signs and symptoms, but it is given there. So presence of contrast blush. So what is contrast blush on CT scan? In CT scan, contrast blush is a sign of active bleeding. So what actually is contrast blush? If you give a contrast and it get accumulated at a certain region, that means there is active bleeding there. So that is contrast blush. So even the presence of active bleeding or contrast blush is not a indication for operative management. You can still do non-operative management. This may indicate the need of adjunctive angiography or embolization. Contrast blush. Contrast blush can indicate the need for adjunctive angiography or embolization, but not necessary immediate surgery. Right? So I will repeat again. Even if there is high grade spleen injury, if the patient is old, if the neurological status is deteriorating, and if even if there is a presence of contrast blush, then you will go for non-operative management. If the patient is hemodynamically stable, there are no signs of peritonitis, there is appropriate monitoring environment, and absence of any other injuries. I hope this is clear. So what are the criteria of surgery? As per our discussion till now, what are the criteria for surgery? It is hemodynamic instability, persistent bleeding, signs of peritonitis, failure of non-operative management. I hope this is clear from the previous two slides. So coming to penetrating abdominal trauma, we will talk a little bit about penetrating abdominal traumas. So gunshot wounds. What are the most common injuries in gunshot wounds? Small bowel or large bowel injuries. See, in blunt trauma, solid organs get injured. In penetrating trauma, small bowel or large bowel, hollow organs get injured. So remember this. Okay. Almost always require extrapolatory laparotomy. Gunshot wounds always require extra exploratory laparotomy. Wound exploration in ER is not performed because it cannot follow tract. So what do we mean by that? So in gunshot wounds, there is a tract because gun is a very high momentum. What do you call it? Has a very high momentum, so it can create a tract. So your finger cannot explore the whole tract. Finger cannot explore the whole tract, right? So we will not use our finger to follow the tract or to explore the tract because we can miss the finding, we can miss the extent of injury. So that is why wound exploration means using your hand or using your finger to explore the tract is not performed. But in stab wounds, you can do the wound exploration because it is not that deep. So coming to stab wounds, what is the most common injury? Small bowel. Surgery for hemodynamic instability or protruding viscera. If there is hemodynamic instability or if there is protruding viscera, then you will do the surgery. In stable patient, we can do wound exploration in AR with a gloved finger or CT scan. And we will do the observation if there are no major internal injuries, patient is hemodynamically stable and there is no protruding viscera. No protruding viscera. Then we will do the observation. Hope this is clear. So another thing I want to mention here is abdominal compartment syndrome. So what is abdominal compartment syndrome? It occurs in patients who are treated in ICU for a very long period of time. So what happens? There will be elevated intra-abdominal patient. If there is trauma, burns or sepsis, so fluid can extravasate and it can increase the intra-abdominal pressure if the patient is treated in ICU for a very long period of time. So it presents as tense, distended abdomen. It may impair venous return, renal perfusion or ventilation, and cause bowel ischemia or multi-organ dysfunction. So that is abdominal compartment syndrome. So how we diagnose the abdominal compartment syndrome? We measure the bladder pressure. So we will fill the bladder with the fluid and measure the pressure. The normal pressure is 4 to 7 mmHg and the intra-abdominal hypertension, if it is greater than 12 mmHg, then we will do the surgical decompression. We will temporarily open the abdomen until the pressure falls. So that is abdominal compartment syndrome. So this is from my end, and thanks for watching my video. And if you like this, please subscribe the channel and like the video and share it with your friends. Thank you.